And next we're going to move on to a presentation by one of my colleagues, Dr. Ray Hong. Dr. Hong apparently was too busy to provide information regarding his biosketch, allowing me to say whatever I wish. And so one of our colleagues offered the thought that the guy is too cool for school. I chatted with him. I think he spent some time studying in Chicago at Rush and at Cook County and in Cleveland at University Hospital. But in fact, he's been all over. And so I'll just say that he's just the best rheumatologist in the country. And he's here to talk about an increasingly important condition in our aging population, which is polymyalgia rheumatica. Dr. Hong.
Stan, I told you, you're the best hype man in the game. You are. I'd like to thank the Cleveland Society of Rheumatology. It's been a great presentation. I really appreciated the talks. The quality of the talks and the speakers has been fantastic. It'll dip down for the next 40 minutes or so, but rest assured, the balance of the morning, it'll come back up. Metro Health, the organizers, Drs. Antonelli and Weinberger, thank you very much. The team, I know it's been a lot of hard work, and I've been witnessing the effort, so thank you for that. And it's great to be back on the Case Western Reserve University campus. I know that we've had this meeting here before. It's a really beautiful space. For those that aren't from the Cleveland area, this is a very historic and esteemed institution. In 1967, it was a federation between Western Reserve University, which was founded in 1826, and the Case Institute of Technology, which was founded in 1880. And it's gone through various mottos through the years: Veritas, Lux, truth and light. I saw a more recent one, which was think beyond possibility, so very, very inspiring. But just last month, I met a patient who had graduated from Case Institute of Technology before the merger. And he said at the time, the motto at Case was, learning is suffering. So not quite as inspiring. As it relates to this talk, I will provide the suffering. If there's any learning, it is all incidental. So let's get into it. I have no disclosures. I know that we have rheumatologists and non-rheumatologists in the room, so for level setting for polymyalgia rheumatica, this condition was first described in 1988, and it went through a variety of nomenclatures: secondary fibrositis, periarthrosis, humeroscapularis, myalgic syndrome of the aged, anarthritic rheumatoid disease, and then in 1957, Barber first introduced the term polymyalgia rheumatica, and the term has gained traction since then. Its epidemiology, it's common in the elderly, rare in those under the age of 50, more prevalent in women. There's a progressive increase with aging, and the peak incidence is in our 8th decade of life, between that 70 to 79 years age group. And it seems to be, the incidence seems to be higher in those of Scandinavian background. So in Sweden, it was 50 cases per 100,000. In Olmsted County in Minnesota, where there's a denser Scandinavian heritage, it was 63.9 per 100,000. When you look in Southern Europe, there's lower incidence, and certainly in South America, Africa, Asia, there'll be incidents that are likely to be lower. Clinically, this condition impacts individuals typically 50 years and older. And near universally, there's pain with restricted motion and stiffness of the shoulder girdle. And 50 to 90% of the time, there'll be symptoms with the balance of the proximal girdle. Morning stiffness is prolonged 30 minutes or longer, and there can be inflammation of periarticular tissues in the joints, an elevated sedimentation rate and/or C-reactive protein. And corticosteroids are and have been the mainstay of our management. Dr. Ardone, I caught your slides, and it was very nice. I saw the purple motif throughout the slides. That was a nice touch. Lupus, of course, there's a purple motif. PMR does not have a color motif, so I just created my own color motif. So bear with me with these colors. There's been multiple classification criteria that have been proposed. On the screen are 4 of such. And Dr. Rodone, you mentioned that every, 5, 10 years, there's different criteria. Here there was a lot of activity. You'll see there were 4 criteria proposed between 1979 and 1984. The BIRD criteria, so we'll see these clinical features that we're familiar with PMR. Bilateral shoulder pain. In this particular criteria, it said it was more acute. It was onset of illness within the past 2 weeks, elevated sedimentation rate, age of 65 and older. There could be depression, weight loss, arm tenderness, and a probable diagnosis involves 3 or more criteria. With the Jones and Hazelman, you'll see some similarities, but you'll see that they proposed a longer course of symptoms of 2 months or longer. They introduced the concept of a negative rheumatoid factor, absence of other muscular conditions, and something that a lot of us clinically feel is a big part of PMR and us trying to establish the diagnosis is an exquisite response to steroids. Huang and Hunder, this criteria set really seemed to be the more popular one. So when you look at the literature in the 80s, 90s, and the aughts, they often reference the Huang and Hunder criteria. It's age over 50 or 50 or greater. There's pain in the neck or torso, shoulder, upper arms, hips or thighs, elevated sedimentation rate, and then an exclusion of other conditions, particularly giant cell arteritis and rheumatoid arthritis. And requiring all of those elements in order to claim the criteria. And finally, the Healy criteria, and we'll see some similarities. In this particular criteria, they actually recommend a steroid dosing of 20 milligrams or less is what's required to elicit the response. So there has been some time between 1984 and 2012, but ACR-EULAR did present a provisional classification criteria in 2012. And similar to the lupus criteria, this has entry criteria. In the lupus criteria, there's a positive ANA. In this particular criteria set, the entry criteria are age 50 and older, a bilateral shoulder aching with an abnormal C-react protein or sedimentation rate. And then there's the introduction of ultrasound or no ultrasound. So again, that's the entry criteria. There's weighted elements thereafter where you would want to have either 4 points if you do not use ultrasound or 5 points if you do use ultrasound. And that would be morning stiffness greater than 45 minutes, hip pain or restricted motion. We again see the negative rheumatoid factor, but also the introduction of a negative CCP antibody in this criteria set. And of course, the ultrasound is what's very unique with this classification criteria. And we'll see that there'll be identification of bursitis, tenosynovitis, or synovitis in joints that are more proximal. So how does this provisional criteria set perform? Well, in one study in Italy, it had the highest discriminatory ability as compared to the other 4. So they followed newly diagnosed PMR patients, and the diagnosis was established prospectively over the course of 12 months. And there was a control group of rheumatoid arthritis and inflammatory arthritis patients. The ACR-EULAR criteria was felt to be the most sensitive at 92.6%. And with the addition of the ultrasound, the specificity was at 91.3%. However, as we also see clinically and diagnostically, sometimes it can be challenging in some patients. So the discriminatory ability maybe starts to dip when we're considering seronegative arthritises. And this criteria set may perform well in North America and Europe, but there's questions of does it perform as well outside. For instance, in Asia, there was a population in Japan, and it only classified 43% of the individuals that were felt to have PMR. We do like to rule out mimics of PMR, and I know this is small, but we're familiar with these seronegative arthritises, spondyloarthritis, crystalline arthritises, infections, malignancies. Of course, because we don't necessarily have a pathognomonic diagnostic tool. So we do like to rule out the mimics. Is this a vasculitis? Is it an autoimmune condition? Is it autoinflammatory? Certainly there's a question of what relationship to vasculitis it may have. 15% of individuals with PMR may have GCA. 40% of individuals with GCA may have PMR. Again, we have no pathognomonic biologic or imaging testing for PMR diagnoses. And our diagnosis really aims to try to find features that support the PMR, but also rule out the differential diagnosis. And we don't have clinically useful antibodies. We may have antibodies that perhaps are just found incidentally as epiphenomenon. For instance, ANCA, non-MPO, non-PR3 ANCAs, anti-ferritin peptide antibody, cardiolipin antibodies occasionally will be identified. But again, their diagnostic utility is not really high. This particular author, Dr. Allegria, in 2020 released an article looking at his perspectives on the pathogenesis of PMR and exploring, what's been looked at so far. So alleles and polymorphisms in PMR. And some have been felt to be associated with PMR, HLA-DRB1, ICAM, RANS, TNFA2, IL-6, for example. But others have not been felt to be associated with PMR, such as interferon gamma. There's been a lot of exploration into peripheral blood lymphocyte subsets in PMR. Activated T cells increase. Activated T cells decrease and effector and memory T cells decrease. We have an increase in pro-inflammatory Th1 and Th17 responses. As this is a disease that seems to be more prevalent in the elderly, the senescence seems to be interesting. So senescent T cells with an T2D marker have been identified. Changes in B cells, mature, naive, IgM-only memory, switch memory, and double negative and plasmablasts are decreased. And these can lead to associated increase in BAFF and interleukin-6. So what's happening in the tissue level, right? A lot of our exploration has been in the peripheral blood because our diagnostic pursuits have generally been non-invasive procedures, right? Been peripheral blood laboratories, ultrasounds, but they really haven't been invasive procedures. But there have been some studies looking at what's happening at the tissue level. So maybe this will give us a bit more insight. For instance, interleukin-6 identified in the synovial fluid. Looking at vascular biopsies, we'll see T cells producing interleukin-1, interleukin-6, TNF-alpha, and PMR, and GCA similar, but the addition of interferon gamma. And then in synovial tissue, the identification of macrophages, T cells, chemoattractants, vasoactive peptide, VEGF. So in this particular cartoon, it just proposes possible pathogenesis. In the periphery, we see an immunosenescent T cell. And then within the tissue, we'll see the macrophages, the T cells, the interleukin-6, ICAM, VCAM, interleukin-1. So how do we manage polymyalgia rheumatica? Well, ACR-EULAR did release their guidelines in 2015. This was the grade methodology that we've been familiar with, that they've been using for the decade or more, using PICO questions. And the target population was patients with PMR, but not with concomitant PMR and GCA or rheumatoid arthritis. And they also identified target users, not just someone who specializes in PMR, but the general rheumatologist and also the primary care physician and provider was included. This guideline was targeted for. It was an international panel. At that time, it was right before ACR was welcoming the patient advisory groups, but subsequent guidelines, of course, do have the patient advisory groups. And we've seen the familiar strong recommendations, conditional recommendations for or against. If you may recall with the grade methodology, a strong recommendation would be multiple people or different people looking at the same data are highly likely to come to the same conclusion. Whereas a conditional recommendation would be when people look at the data, they may come to the same or a similar conclusion, but there's room for disagreements. And this is where shared decision-making between the patient and the physician or provider is very important. There were multiple overarching principles that are certainly intuitive, trying to have an individualized plan. Trying to educate the patient, but there was also some prescriptive recommendations. So they recommended that all individuals prior to a prescription, they have a rheumatoid factor, a CCP antibody, a CRP and/or sedimentation rate, CBC, glucose, creatinine, LFTs, some sort of bone panel. There was also consideration based on signs or symptoms for checking an SPEP, TSH, CPK, vitamin D, ANA, ANCA, tuberculosis, and chest X-ray. So this breaks up the recommendations into strong for, strong against, conditional for, conditional against. And there's a strong recommendation for glucocorticoids instead of NSAIDs, and using the minimal effective individualized duration of steroids. There's a conditional recommendation that the initial dose of prednisone should be 12.5 to 12.5 milligrams per day. And a strong recommendation against, we're kind of jumping down to the bottom left, a strong recommendation against prednisone doses of 30 milligrams or higher to start. There's a conditional recommendation against an initial dose of 7.5 milligrams or lower with prednisone. Jumping back up to the conditional on the right, conditional for on the right, you'll see number 5. Intramuscular methylprednisolone is a conditional recommendation as an alternative to oral glucocorticoids. Once daily dosing of prednisone as opposed to split dosing is a conditional recommendation for. Considering early introduction of methotrexate in those patients where you think they're at higher risk for not responding as well to the steroids, having complications to the steroids alone. And a strong recommendation against the use of TNF-alpha blocking agents. So in this schematic, I wanted to highlight just an example of what it would look like for the ACR-EULAR guidelines for how to wean prednisone. So let's take an initial of 12.5 to 25 milligrams, and you'll see here that this one mocks up a 15 milligram per day starting dose. And monthly, you're seeing these decrements down to 12.5, then down to 10 milligrams by the time you're at month 2, 10 milligrams per day, and then every month thereafter, dropping 1 milligram per day per month. So at month 3, it's 10 milligrams per day. At month 4, it's 9 milligrams per day. And eventually, after 12 months, assuming that there's been no relapses, you may be able to stop the prednisone. What's the data on the intramuscular methylprednisolone? Well, in this particular protocol by Dr. Dasgupta, these were, it started with every 3-week intramuscular methylprednisolone injections, 120 milligrams, and then the dose and the interval between the injections would slowly, the dose would slowly decrease, the interval would slowly increase. The benefit of this is the cumulative steroid dosing was approximately half of the previous regimen that I showed. And their data show that there were similar remission rates between intramuscular methylprednisolone given at these intervals versus daily oral prednisone of 61% versus 67%. However, looking at the data, the oral prednisone group did seem to have more rapid control of their PMR, and there was a higher steroid discontinuation rate in the oral prednisone group. So this led to the conditional recommendation for the guidelines of oral prednisone over IM methylprednisolone. What happens if we try to taper the prednisone too quickly? Well, the concern is relapse will occur with a rapid taper of prednisone. So in this particular study, this was out of Mayo Clinic, and they were able to create a computer model looking at their database of individuals with PMR. They were able to use a computer model that could predict how physicians and patients were going through their taper. And it was split into a slow taper group, a medium taper group, and a fast taper group. And you can see over here with the fast taper group at 120 days, we'll see that the curve really flattens out. So in the fast taper group, they're essentially coming off steroids in about 4 months, whereas you can see in the slow taper group, even at 10 months, the curves are still increasing. And on the graphic to the right, we'll see that the relapse rates are much higher in the fast taper groups as opposed to the slow taper group. So at 1 year, the relapse rates in the fast taper groups are about 70–75%, whereas at 1 year with the slow taper group, it's approximately 10%. Chronic steroids is an issue with our patients with PMR. So half of our patients, at least per this analysis, half the patients were still on prednisone at 2 years. This particular meta-analysis pooled data from 21 controlled trials in PMR. And at 1 year, 77% of patients were still on prednisone, and that was consistent whether it was a retrospective study or a prospective study. At 2 years, it was approximately 51%, and a few studies there was even 5-year data where 25% of patients were still on glucocorticoids at that point in time. Relapses were high. 43% of individuals had one or more relapse at 1 year. And recurrence is defined as your disease is in remission, you're able to come off your prednisone, but then the PMR comes back. That's the recurrence definition in PMR. And somewhere between 5 to 37% of individuals had a recurrence of their PMR, with the longest being 44 months after stopping glucocorticoids, again, in this particular meta-analysis. What happens in real-life practice? Well, in real-life practice, the same thing happens. So this is actually data that was just published in 2023 using the ACR RISE registry. The ACR RISE registry is connected to over 20% of the rheumatology practices in the States, and it includes 2.4 million patients. So with this data, it was about 26,000 PMR patients in rheumatology practices, and you'll see the Sankey plot, and essentially I hope I'm not blinding anybody. Okay, there we go. Essentially, we're seeing the glucocorticoid group, even this purple is faded as continued steroid use. So at 13 to 24 months, these individuals are still on steroids, again, from rheumatology practices. Now, again, these were people that at their first visit with rheumatologists, and it certainly could have been patients that were transferring care or were already on steroids from a referring provider. But the point being, rheumatologists are keeping their PMR patients on steroids for a long time. Dr. Sag showed this same slide in the fact that we do have concerns about toxicities from glucocorticoids. In this particular graphic, we'll see that this was an analysis of Medicare claims data as well as Optum data, so commercial data of individuals with rheumatoid arthritis looking at the bins of no prednisone versus prednisone less than 5 milligrams per day versus prednisone 5 to 10 milligrams per day or prednisone 10 milligrams per day or higher. And regardless of your dose of prednisone, any of the prednisone groups, the hospital infection rates were higher than no prednisone. And if you were on 5 to 10 milligrams in both the Medicare claims and the Optum, the risk was about double as opposed to if you were not on steroids. We also see there was also the identification of more opioid use, more outpatient visits, more hospitalizations, and in the Medicare group, there was more ED visits for those that were on prednisone. So we're in search for a steroid-sparing agent. What can we do? What can we offer for these patients besides steroid monotherapy to try to control their condition, wean their glucocorticoids? And one question is, does methotrexate work? So there's been 4 controlled trials with methotrexate, 2 of which give favorable data, 2 of which give unfavorable data. The doses in these trials were low. They were 7.5 milligrams to 10 milligrams per week, at least low per our modern day standards. For the standards at that time, those were typical doses that were used with methotrexate, even in rheumatoid arthritis. And in the studies that suggest there's some benefit, the benefits are improved remission, improvements in remission, lower relapses, more glucocorticoid discontinuation, and lower cumulative glucocorticoid doses. So there is some suggestion that methotrexate provides some benefit, and as you saw before, the ACR-EULAR guidelines conditionally recommend methotrexate for those that you identify may have some risks. Because the quality of evidence was felt to be higher with the favorable studies than the unfavorable studies. So this is just one example of methotrexate works. This is probably the best study that's been out there. It was from Caporali. It was a randomized, double-blind, placebo-controlled trial with recruitment between 1998 and 1999. There were 72 patients assigned to either methotrexate plus prednisone or placebo plus prednisone, and then a tapering of the prednisone over 24 weeks. And in this particular study, again, it's kind of small, but you'll see over on the column to the right, at 76 weeks, there were less patients on prednisone in the methotrexate group than there were in the placebo group. On the other hand, methotrexate doesn't work. This was out of the Netherlands, and this was another randomized double-blind placebo-controlled trial. This one had 40 patients. There were a few that had GCA. It was mainly PMR. They did a biopsy on a temporal artery biopsy on 37 patients, 6 of which had positive biopsies, 3 had symptoms, 3 did not have symptoms. And some of the group was placed on methotrexate, another group was placed on placebo, and they found no difference between the groups. However, this study was felt to be, again, not as high quality evidence. The dropout rate was high. 19 patients dropped out. There were multiple malignancies that were ultimately diagnosed, or inflammatory arthritis that were arthritis that were diagnosed. And then, of course, there were some GCA patients in the mix here. So what are next steps for methotrexate? There was a meta-analysis that showed that favored, between these 4 studies, favored the benefit of methotrexate. We've not looked at methotrexate in higher doses as of yet, but right now in the Netherlands, they're recruiting for the PMR mode study, which is looking at methotrexate at 25 milligrams per week. So more to come on if methotrexate is beneficial or not. How about TNF-alpha blockade? Well, we saw a strong recommendation against TNF-alpha blockade based on this study. The infliximab plus prednisone, no better than prednisone and placebo. And you can really see the flare-free survival curves are really overlapping one another. How about other therapeutics? We've looked at T-cell co-stimulation with abatacept. Some initial interest and favorability in the Allure study published last year. This is the manufacturer's phrasing. The abatacept sub-Q weekly effect was not strong enough to justify larger studies in early polymyalgia rheumatica. So there was some extra phrasing of, this may not be the end of the story, but this was their verbatim quote, is does not justify larger studies in early PMR. Bridge PMR looked at rituximab, a single dose of rituximab at 1,000 milligrams, did show some favorability, a significant risk reduction in glucocorticoid-free remission at 1 year, 52% versus 31%. I was able to find a small trial, a publication, I believe it was in the Shanghai region, with tofacitinib, a trial of 14 patients with highly active PMR that tofacitinib seemed to be beneficial. And no studies that are published as of yet with PMR in other mechanisms, for instance, IL-12/23, IL-17. There's exploration in GCA, but again, I've not seen publications in PMR. So I wanted to spend some time speaking about interleukin-6. How am I doing on time? Okay. Before I did that, I wanted to introduce the PMR activity score. The PMR-AS is made up of these elements: the C-reactive protein, the patient's pain score, the physician global score. It also takes this interesting morning stiffness in minutes, the MST, multiplied by 0.1, and then it takes the elevation, the ability to elevate upper limbs. So if you have no ability to elevate your upper limbs, if you're at 0 degrees, you would have a score of 3. If you're able to elevate less than 20 or 90 degrees, your score is 2. If you're at 90 degrees, your score is 1. And if you're over 90 degrees, you have a score of 0 with the EUL. A high activity is greater than 17, moderate 7 to 17, and low activity is less than 7. So in the tocilizumab studies, there's a reliance on the PMR-AS. And the first one published was the Semaphore study. This was safety and efficacy of tocilizumab versus placebo in polymyalgia rheumatica with glucocorticoid dependence. And this was a phase 3 randomized double-blind placebo-controlled trial performed in France. The investigators were blinded to the CRP. We're concerned about tocilizumab. It's an impact on CRP, and will that bias results? So the investigators were blinded to the CRP, although in this study, the investigators were allowed to look at the PMR-AS at the end of each visit. The target population was PMR patients who had initially responded to prednisone, but when the prednisone was reduced to less than 10 milligrams per day, they had a relapse of their PMR symptoms or their PMR activity. The intervention for this trial was tocilizumab intravenous, 8 milligrams per kilogram every 4 weeks, and the prednisone was tapered. It was fixed for 8 weeks and then tapered, so there's a total duration of 16 weeks of prednisone in both the active medication group and the placebo group. The primary endpoint was this composite endpoint of a PMR-AS of less than 10 and prednisone dose of 5 milligrams or less per day, or your prednisone dose was reduced by more than 10 milligrams from baseline. And this was a favorable study where the tocilizumab met its primary endpoint and multiple secondary endpoints. The PMR SPARE study, this is tocilizumab in patients with new onset PMR. This was a phase 2-3 study. It was conducted in Austria. And again, the investigators were blinded to the CRP and the sedimentation rate levels. This time, the target population was new onset PMR patients. So the first study was perhaps a more refractory population. These PMR patients were newly diagnosed. And the intervention here was tocilizumab 162 milligrams subcutaneously weekly. The prednisone was started at 20 milligrams a day, and then there was a relatively rapid tapering of prednisone over the course of 11 weeks in both the active medication group and the placebo group, with the primary endpoint of glucocorticoid-free remission at 16 weeks. So a short trial. They did follow for another 6 weeks thereafter. And we see with the graph on the table on the left, tocilizumab had more glucocorticoid-free remission. It was at 58%, at 16 weeks, it was at 63% versus 12% in the placebo group. In the middle graphic, less likely to relapse. And in the graphic all the way to the right, there's a lower cumulative steroid dose. I flipped that around. The graphic all the way to the right is the relapse, and the cumulative steroid dosing is the bottom graphic in the middle. The SAPPHIRE trials, this is sarilumab for relapse of PMR during glucocorticoid taper. This was a phase 3 trial, randomized double-blind placebo-controlled. It recruited between 2018 and 2020. There were some problems with recruitment during this trial due to the COVID pandemic, so they repowered before there was any data analysis for a smaller recruitment population. The target population is, again, a more stubborn group of PMR activity. These patients had PMR, and they ended up flaring when the prednisone was reduced to 7.5 milligrams or less. That was the target population here. The intervention was sarilumab, 200 milligrams sub-Q every 2 weeks. And this time, different than the tocilizumab studies, we have different tactics in the prednisone. So in the active medicine group, the prednisone was tapered over the course of 14 weeks, whereas in the placebo group, the prednisone was tapered over the course of 52 weeks. And the primary endpoint was clinical remission with a resolution of signs and symptoms and C-reactive protein of less than 1. There was no disease flare, sustained normal CRP, and adherence to the steroid protocol at 52 weeks. So a longer-term study. And what we see here is sarilumab was superior to placebo at sustained remission. So in the column to the right is the primary endpoint at week 52 of sustained remission. The columns to the left are elements of that sustained remission. But we'll see that 28% versus 10% of individuals had sustained remission if they were on sarilumab versus placebo, respectively. And even if you eliminate the sedimentation rate and C-reactive protein from the sustained remission calculation, the numbers were very similar, and the difference between the groups was both 18%. And we'll see a trend for less PMR symptoms or fewer PMR symptoms, signs and symptoms with sarilumab versus placebo. And PMR flares trended up in placebo as compared to the sarilumab, as you'll see in this graphic. As a result of this study, sarilumab is now FDA approved for the treatment of polymyalgia rheumatica and those who are unable to wean from steroids, or who are not completely responsive to steroids, excuse me. Interestingly, with sarilumab, they also showed improvements in quality of life. So SF-36, physical and mental components, fatigue, HAQ-DI, the Physician Global, those had improvements, whereas in one of the tocilizumab studies, there was no improvement in these elements, and another one, there were improvements. So comparing the prednisone dosing between these trials, just to remind you, this is the ACR-EULAR recommendations, starting at 15 milligrams and weaning slowly over the course of 12 months. And what we'll see in the tocilizumab trials, the blue highlights the both active medicine and placebo arms. So whether you're on active medicine or whether you're on placebo, both groups had a very shortened duration of prednisone at only 16 weeks. So you're really pressure testing this group of PMR patients, and you're challenging the placebo group to flare. You know, we've already established that flares very likely even when you go through a 1-year taper of steroids. Here we're only doing a 16-week taper of steroids. So you're really trying to induce a difference between the active medicine group versus the placebo group. Similar in the PMR SPARE trial in the lavender is the prednisone taper for both the active medicine and placebo group. Again, we're really trying to induce a flare in the placebo group and really highlight a response in the tocilizumab group. On the other hand, in the SAPPHIRE trial, this was in this trial the active medicine group had a steroid trial that was abbreviated, just at 14 weeks. And the placebo group had guidelines, basically the standard recommendations for how you might decrease the prednisone. So what you'll see with the colorful steroid taper is very similar to just the mock-up that I made of the ACR guidelines. This is the steroid taper protocol that the SAPPHIRE group used. So in this, by comparing tactics, you're really saying, what does sarilumab in a very challenging population of PMR patients that have already proven themselves to relapse, how does it perform versus standard of care versus how does it perform versus just this abbreviated prednisone dosing? So I would argue that the sarilumab trial design really had a higher hurdle to achieve in order to show the difference. Well, part of the point of this is we'd like to make our patients feel better. We want something that's successful, but another part of this is we'd also like to show fewer side effects. Our concern is glucocorticoid toxicity, amongst others, and what impact does it have on adverse effects, or what impact do these medications have on adverse effects? So there is something called the glucocorticoid toxicity index. It measures GC toxicity between 2 points of time, and it's a composite measure of cumulative worsening score and aggregate improvement score. So the cumulative worsening score is sort of a lasting record of any glucocorticoid toxicity, whereas the aggregate improvement score, that toxicity is removed if it resolves. It's made up of 9 domains, 31 items. Those domains are BMI, glucose tolerance, blood pressure, lipid metabolism, bone mineral density, steroid-induced myopathy, steroid skin issues, neuropsychiatric issues, and infections. This GC, the glucocorticoid toxicity index, is validated in a severe asthma cohort. In the SAPPHIRE trial, we did not see any significant difference in the GCTI between the active medicine and the placebo group. So we'll see some trends towards improvement. The cumulative worsening score was a bit lower than in placebo. The aggregate improvement score was better than placebo, but not statistically significantly different. We did see in the bone health domain, which is the bone density decline has to be 3% or more, and there were fewer patients in the sarilumab group that had that degree of bone density decline as opposed to the placebo group. Now, the GCTI may not be validated for this dose of steroids. Again, it's validated in severe asthma. It's been used in trials, for instance, the EGPA trials with mepolizumab. It's been used. Is it sensitive enough to detect toxicity changes at prednisone at this dose? And then looking across the adverse events tables between the groups, we're not necessarily seeing a decrease in adverse events in the active medication group. So yes, we do have medications that seem to be of benefit. We're still trying to establish if these truly reduce the risk of steroids. I feel like I'm getting the hook. I see a little activity there. So much like the Golden Bachelor couple that had to call it quits, I'll have to call it quits as well. We see PMR as condition of proximal pain. We have classification criteria that exist, but they still require some validation. Areas to explore may be the tissue changes, more so because there's been a lot of exploration in peripheral blood. Our management is still incomplete. Many patients are still on prednisone for 2 years. We do have steroid-sparing agents that are available, including interleukin-6, but we've got unmet needs that we still need to pursue. So thank you very much.